Hi, I'm Jim Glidewell, and I began making porcelain fused to metal restorations in 1968. Since that time, Glidewell Laboratories has fabricated over 2 million PFMs, which remain the most prescribed option for aesthetic crowns and bridges. This video will introduce unique clinical techniques for preparation and impression taking, which will save you chair time, increase productivity, and improve restorative results. These techniques have been proven successful by our in-house clinician, Dr. Michael DeTola. By the end of this video, we hope you'll agree that by using the techniques discussed and sending your casework to Glidewell Laboratories, you'll receive the best PFMs for your patient. Now let me introduce Dr. Michael DeTola. He is our Director of Clinical Education and Research, working closely with our Research and Development Department, as well as providing chairside education to our technicians and phone staff. Dr. DeTola graduated with honors from the University of Pacific in 1988, earning a Doctor of Dental Science degree. He is a Fellow of the American Academy of General Dentistry, a graduate of the Las Vegas Institute of Cosmetic Dentistry, and the PAC-Live program, and is one of the editors of Contemporary Aesthetics and Restorative Practice magazine. Dr. DeTola.
Thank you, Jim. One of the most common and more productive procedures performed in general dentist's office is crown and bridge, the majority of which is still porcelain fused to metal restorations. I haven't met a dentist yet who doesn't enjoy performing these procedures, and what I want to show you today in this video presentation are some products and some procedures that will make your fixed prosthodontics better, more productive, more profitable, and will leave your patients happy with the quality of your restorative work. On this first case, where superior aesthetics are mandatory, I will be prescribing Captur. Captur is porcelain fused to 22-karat gold copings that are a rich yellow color, assuring that you will have no dark metal margins on your restorations. The rich color of the coping mimics the color of a natural vital tooth, which is why Captur restorations are sometimes mistaken for all ceramic restorations. Captur has also been clinically documented to have lower bacterial accumulation rates than any other material, including even enamel. We are going to prep 4 maxillary anterior teeth, teeth 7 through 10 on her. Typically we try to either stay within the cuspids and do the 4 anterior teeth, as we're going to do in Andrea's case, or go all the way back to the first or second bicuspids. We really try to avoid just doing 6 units from cuspid to cuspid, because the cuspids end up looking way too prominent by the time the final restorations are placed, and the bicuspids tend to disappear into the dark buccal corridor, and it doesn't look good when the patient smiles. This is the occlusal view of teeth number 7, 8, 9, and 10. Again, you can see some old amalgams in place with some recurrent decay underneath it. During my interview with Andrea, she indicated that she likes not only the shade of tooth number 9, but the size and the shape of tooth number 9 as well. So we're going to use this as our reference tooth, if you will. We've taken photographs already of this tooth that we will send to the laboratory technician, and what we're going to do to use it as a reference tooth is prep tooth number 7, tooth number 8, and tooth number 10, and then take an impression with those 3 teeth already prepped and tooth number 9 untouched. Shade selection on this case is relatively straightforward since we are preparing teeth number 7, 8, 9, and 10. Our patient has already told us that she likes the shade of tooth number 9, and it's got a relatively high value. I'm looking at it next to a B1 shade guide here, and they appear to be relatively close, so we will use B1 as our final base shade. Before we begin the tooth preparation, we will go ahead and address the gingival situation. This is the tissue trimmer from Axis Dental. This is a ceramic tip. It fits into a high-speed handpiece, and we're going to use this in our high-speed handpiece and take it around to just trim some gingiva around tooth number 8 and try to match the gingival height and the gingival zenith that we see around tooth number 9. You'll notice we use this without water. That actually impedes the coagulation in the capillaries and can lead to a little more bleeding in the area. So this tip does work better and should be used without the water spray. As with the other preparations in this presentation, we will begin by preparing the cervical margin. We've now completed the depth cut in the gingival third of the teeth with the round bird that we've been using. You'll notice the saucer or smile shape reduction depth cuts right along the gum line. We're staying clear of the gingival tissues here. We don't want to touch it until we have placed our first retraction chord, which we'll do a little bit later. You'll notice we haven't placed any depth cuts on our reference tooth here because, of course, we want to leave this tooth unprepared and untouched so we can take the alginate that we'll pass on to the laboratory technician to help them match the size and shape of that tooth. The next depth cut will be performed in the incisal third of the tooth with a 330 burr. This is a standard 330 burr. The head, the cutting portion of the 330 burr, is exactly 2 millimeters long, and we would like to have 2 millimeters of incisal reduction here, so we'll begin the next phase of preparation by placing our 2 millimeter incisal edge depth cuts. So this is an 856-016 burr. This burr is 1.6 millimeters thick at the top of the shank, and at the tip is 1.2 millimeters thick. So we can use each of those dimensions on the different planes. There's 3 planes, of course, to the facial surface. There's the gingival third, the middle third, and the incisal third, and we're going to make depth cuts accordingly. We'd like to have at least 1 millimeter of reduction in the gingival third, and we'd like to have 1.5 millimeters of reduction in the middle third, and then the 2 millimeters of reduction on the incisal edge that we've already accomplished, and then smooth those together so those 3 planes form a nice smooth contour to our preparation. As you can see, we've now completed the incisal and facial and gingival depth cuts. At this point, we're going to take, I prefer a 169L burr, very thin burr. We're going to break contacts between our teeth so we can place our first chord. Then we're just simply going to connect the depth cuts we've already made to assure adequate reduction. You'll note we haven't placed any significant depth cuts on the lingual surface of the teeth, and that's because the opposing teeth usually give us a very good indicator of whether or not we have enough reduction on the lingual. We don't have that luxury on the facial surfaces or the incisal surfaces of the teeth, which is why the depth cuts come in handy. We're going to begin to place our first chord. This is an Ultra Pack 00 chord from Ultradent, very small, a knitted chord, so it's hollow. This is non-medicated and there's no medicaments on it, so we can place this chord in and leave it in for a long period of time without having to worry about any adverse effects on the gingiva. This allows us to, when we go in and work in the area of our gingival depth cut, we're able to place our gingival margin 0.5 millimeter into the sulcus without having to worry about damaging the gingiva because of the retraction we receive from this first retraction chord that we're now placing. We'll go ahead and place this around all the teeth at this point. The first chord has now been placed. You'll notice we've cut the ends. There is no exposed chord. That's because this chord is going to stay in place throughout the entire impression procedure. We'll place a second chord on top of this chord about 5 minutes before taking the impression, and we'll pull that top chord. We'll leave this bottom chord in here, usually until we've actually cemented the temporaries into place, and then we'll take that chord out and remove the temporary cement with it. So the first chord is in, it's flush, none of the ends are sticking out. You can already see our gingival depth cut, for example, on this lateral incisor that was at the level of the gingiva. The gingiva has now been retracted about 0.5 millimeter. By the first retraction chord. And so now at this point we're going to blend all of our depth cuts together on the facial, the incisal, and we're going to drop the margin down to the level of where the gingiva is now. And so when the retraction chord is out and the tissues have come back, our PFM margin is going to be about halfway into the depth of that sulcus, about 0.5 to 1 millimeters under the free gingival margin. The lingual reduction will be accomplished with the football burr, which will give us the concave lingual surface that we are looking for. Here is the lateral incisor. Immediately after removal of the old restorations, you can see some areas that appear to still be carious. We'll go ahead and use a caries detecting solution, seek a green solution, a green dye, to check for the presence of caries before we place our filler materials. And one of the good uses of caries indicating solution is, as shown here, there's not nearly as much caries as one might have expected, especially in that lingual pit where there's a darker brown color. There's just a little bit on the distal where that restoration used to be. So we'll go and remove that quickly and then move on with our filler material. Our dental assistant has mixed the Vitribond material. I'm going to place this with a Dical applicator. This is a tri-cure material, so we will need to light cure it here to get it to set. Because of the glass ionomer material's inherent bonded dent, and there's no need for pre-etching on this step, which is nice. We've now placed the Vitribond filler material and smoothed it off, and you can see all the voids are gone. This will leave us with an ideal preparation shape that will maximize our crown's retention and resistance on the preparation. Flexible clearance tabs. These are available through dental dealers and come from Kerr Lab Division. They come in different colors. This one happens to be 1 millimeter thick. The green one happens to be 1.5 millimeters thick. For the rest, it depends on whether or not you're going to have a metal lingual or a ceramic lingual. I'm looking for about 1.25 millimeters of lingual reduction here. So when I have the patient bite together, go ahead and bite down on the 1 millimeter one, and it slips right out. Bite together, and bite together, and it slips right out. And the 1.5 then should be a little snug. Bite together, bite together, bite together. And it's just a little snug, but when she bites together, she comes all the way together on her posterior teeth, even on the 1.5 millimeter. Usually our lingual reduction will increase just a little as we go in and smooth the final preparation as well. Now that we have obtained an alginate impression with the reference tooth in place, we are free to prepare the reference tooth. So we'll go ahead and just repeat the steps we've already accomplished on the other teeth, starting with the incisal edge depth cuts. We're going to use some Softlex discs from 3M SB here to round off any sharp angles that we might have on the preparations. The reason for doing this is thin, sharp incisal angles. When we go to pour those in the laboratory, those little pieces of stone break off rather easily, and we end up with a master model that has a shorter tooth preparation than the patient does in their mouth. Thus, when you get the final restoration back in your office, it will not seat completely because the restoration was made on a model of a preparation that was shorter than the prep is in real life. So we're going to use these discs just to round off any sharp corners we might have, round over any sharp edges we might have that we won't be able to reproduce with our die stone. We are now placing the second chord, the top chord. The first chord has been placed. It's a 00 chord, and now this is a number 2 chord being placed on top of that. The optimum time to leave this top chord in is about 8 to 10 minutes to get maximum retraction. Prior to removing the top chord, we're going to re-wet these. What this does is help release the chord from the tissue. So like a Band-Aid that has been in place, if you wet it, it's easier to remove it without causing any bleeding. So we will re-wet the top chord, remove it, and then start taking our impression. As my assistant fills the tray with the heavy body material, I begin syringing the light body material around the preparation closest to me. We go at least 360 degrees around the tooth, preferably 720 degrees around the tooth to make sure we do not get any pulls from inclusion of gingival fluid or any other moisture that may be present around the preparations. After waiting the 3-minute set time, we now remove the impression. And unlike an alginate impression, because this is a polyvinyl siloxane, we remove it slowly to give any material caught in an undercut a chance to rebound as we take out the impression. We're going to use the Captur hard bite material. I like it because of how stiff it is, how hard it sets. Very quick set time, just about 60 seconds. We extrude it right onto the preps, none of the adjacent teeth, just the preparations. Instruct the patient to bite down into it. Go ahead and close all the way down. Perfect. And hold it just like that for 1 minute. We are now trying in the biotemps by themselves. They should have a passive fit and fit right into place. We are now relining the biotemps with a methyl methacrylate material, and we will leave this in the mouth and check to see when it's going through its doughy stage, and then pump it up and down a few times to make sure we don't get locked into any undercuts. The biotemps restorations have been trimmed and now cemented into place with Temp Unclear. You can see how nice they look. We've actually got some incisal edge translucency. We've got nice shape, nice shade on those. They blend in well. We've tried to open the embrasures, for example, between 8 and 9 to make sure we don't do any damage to those papilla during the 2 weeks while these provisionals will be in place. We would certainly rather leave that a little bit open and allow our papilla to be touched by an interproximal brush or the patient rinsing, as opposed to having too much reline material there underneath the biotemps in an embrasure area and actually cause some recession of that papilla, which could lead to a black triangle situation when we try in our permanent restorations. Before we remove the biotemps, let's take a look at the gingival tissue and how it healed around our provisional restorations. It looks very nice. In fact, you'll recall on tooth number 8 we actually did a little crown lengthening here with that tissue trimmer. And one of the advantages of biotemps is that in the laboratory they are able to make these two teeth, the two central incisors, the exact same length for us, which anticipates our tissue trimming. So once we've gone in and removed the excess gingiva, our biotemp restoration will be just as long on this central as it is on this one. It'll help the healing of that soft tissue so that we get a level that's even for when you look at tooth number 8 and tooth number 9. So as I look at all 4 of the anterior teeth, we've had an excellent gingival response to the temporaries, which is exactly what we need to be able to cement our permanent restorations into a dry, clean field. We're now going to remove the biotemp restorations. Usually it's just curved hemostats just like that and pop them right off. Just about all the temporary cement has stayed on the biotemps and not on the preparation, so we'll have very little cleanup prior to trying in the permanent restorations. We're going to clean the preparations with some pumice. This happens to be the Preppies from Whip Mix, and it's a pre-mixed pumice. It's really nice, very smooth, easy to use, good single-use unidose packaging. And we'll just put it in a Profi cup and polish our preparations. We're ready to try in the final restorations at this time. The best way to do it is to try the units in individually first and assess the marginal fit, and then try them in collectively and check the contacts as well. So we'll try them in individually first. All the units have been tried in individually and they all have excellent marginal fit. So now that we've got them in together, we can go ahead and check the contacts. Andrea had the chance to sit up and evaluate her new crowns in the mirror, and I'm happy to say she loves how they look, so we are now ready for the cementation procedure. Usually we will place a desensitizer on the teeth, and we're going to do that now. This is Hemoseal Inside from Advantage Dental Products. It's a combination of chlorhexidine and Hema, and actually in the latest CRA report did very well in their tests, and we just about always on all of our PFM cementations will place a thin layer of this on and then evaporate it with some air prior to cementation of the final restorations. We've placed the Reliax Unisem into the crowns. We're now going to begin seating them individually. Starting with the central incisors, I will place them first and apply finger pressure to push the crowns down into place. Then I also like to use an orange wood stick just to get a little more pressure and make sure that it's down all the way. I will also use the orange wood stick on the 2 central incisors to make sure that we have the incisal edges lined up, although with the fit of these CapTech restorations, there's no play in these restorations anyway, and there's really only one way that they can seat. And with the Unisem, because it also has a light cure component, our operatory light will start to cure it, and we'll start to clean it off as it goes into its gel stage. With the Unisem, you want to clean it up sooner than later. It's a self-etching resin cement, and it's as strong as any resin cement you've used before, and it's very difficult to get little pieces of cement out from between the teeth and the embrasures once it is set fully. After cleaning the cement off, we're going to use this polishing product from Axis Dental. This is called Chamois. It's a felt wheel along with a ceramic polish, and we will take this along the facial surfaces of the crowns to remove any excess cement and put a final glaze onto our CapTech restorations. We've achieved a very nice aesthetic and functional result. You can see contours look nice, surface texture looks nice embrasures everywhere. Nice incisal edge translucency as you look at the teeth with a nice white halo effect right underneath it. That's exactly what we were looking for. We sent along a photograph of another set of teeth to the technician, and they were able to match that in these final restorations. Contacts were good, occlusions fine, and excursions are fine as well. And you can see we've achieved a really nice result here with some pre-planning, the use of a reference tooth here to kind of help guide the technicians along for the size, shape, and form of tooth that we were looking for. All in all, it's been a really nice case, and patient